name is Amy Wolf. I'm the programming director here at the Osterville Village Library. Thank you so much for joining us today. When it comes to planning for future healthcare decisions, many people feel overwhelmed by unfamiliar terms, complex forms, and difficult conversations. Yet tools like healthcare proxies and MOLST, or medical orders for life-sustaining treatment forms, are designed to do something very simple. Make sure your wishes are understood and respected if you are ever unable to speak for yourself. This program aims to demystify these important documents by breaking them down into clear, practical terms. We'll explore what they are, how they differ, and when each is used. More importantly, we'll talk about how to start the conversation, both with your loved ones and your healthcare providers, so that your values and preferences guide your care. By the end, you'll have the knowledge and confidence to take meaningful steps toward planning ahead with clarity and peace of mind. And here to lead this program is Dr. Sarah Todd of Caregiving Pathways.
Thank you, Amy. Can everybody see me and hear me?
You don't need that. If you don't want to be on camera, you have
Okay, well, I don't mind being on camera. I just couldn't see over the screen of the computer. So I am a practicing emergency medicine physician. I work at Falmouth Hospital and I've been there, it will be 18 years this summer. So I will hit my 21st year as an emergency medicine physician this summer. So I've been at this for a little while and I've seen a few things. I'm also a death doula. And I also am the physician partner for Caregiving Pathways, which is a company that supports family caregivers and helps people make their end-of-life plans. So that's a little bit about me. What's important is why this matters to me so much. This is a picture of my first husband. His name was Evan Weinstein. We met before classes started my freshman year of college. I looked at him and I said, damn, that boy needs me. And we were married for a very long time. He was diagnosed with a brain tumor when, I don't even remember what year it was. Our oldest child was 6 and we had a 1-year-old, and he was also an emergency medicine physician in Falmouth. And what I saw from this experience with him is how differently physicians die. Physicians use a lot less intervention. They ask questions when they're offered treatments and when they're offered options of care, like, what is this going to do to me? How am I going to live with this? His question with the different chemotherapies, he had a brain tumor. So his question with each chemotherapy that was offered to him was, how am I going to be able to be a dad? How am I going to be able to be a husband? Because that was really important to him in making the decisions. He lived for 7 years with his tumor. He was in hospice for the last 2 years of his life. He told me he didn't need it. And I looked at him and I said, but the rest of the family does. Because at that point we'd had another child. So it was myself and 3 children. So that's the big thing that drives me in this. But I also see patients. I see patients in the emergency department. I see people wheeled across the threshold of the emergency department in extremis, where we need to make life-saving decisions as fast as we can. I see their families when I ask if the patient can't speak for themselves. Do you know what your mom wanted? Do you know what your spouse wanted? They don't know the answers, and they feel this tremendous stress and grief because they feel like they're making decisions that are either going to have their person that they love live or have their person that they love die, and they just feel this tremendous amount of pressure. There's oftentimes discordance between what people want and what actually happens. And there's a kind of stepwise process to fill out these forms, specifically the MOLST that we'll talk about. And sometimes I see somebody has a MOLST form filled out, and it's filled out in a way that medically doesn't make any sense. So I want to mention that as well. The discordance, I'll tell one story. I had somebody come in, they had end-stage Parkinson's disease. They lived at home with their spouse. They had a caretaker who was there. I'm not sure they were there 24 hours a day, but they were there many hours of the day. And the patient, her heart stopped, and the caregiver started CPR and called 911. And the husband is 80 plus, sitting at home, typing on the computer, trying to get the advanced care plan that he had made with the attorney printed off. The ambulance came, the ambulance started their resuscitation. The husband finally was able to print off the form, gave it to the ambulance, and they said, we can't honor this. You know, 3 paragraphs of what she wanted if her heart were to stop and how she wanted her care to be given, but they can't follow it. They can follow the MOLST form. So we'll come back to that in a little bit, but this piece that came out a little bit smaller than I wanted it to. This is kind of a guiding principle of end of life care. There is no right or wrong choice at the end of life, but the value lies in making a fully informed choice. So that's what I hope to do today, is help people understand what's available and what choices there are. So we're going to cover the healthcare proxy, resuscitation, MOLST and FOLST order, and we'll talk just a little bit about the living will. So does anybody have a healthcare proxy? Okay. So the healthcare proxy we're going to talk about in just a second. The MOLST and FOLST, that's an order. And the living will is more of the foundation. That's what that husband printed off of the computer that he and his wife had worked out with their attorney of what they wanted. So a healthcare proxy is your voice when you can't speak for yourself. It's someone that you pick and they're able to make decisions for you if you can't make decisions. One of the most important things about this is here. If the healthcare proxy hasn't been invoked, they can't make decisions for you. So that means you just need a physician or another medical provider to say, you can't make decisions. Maybe somebody has had a bad accident, they've had a head injury, and they can't understand and communicate well enough to make the decisions. That's when the healthcare proxy gets invoked. This can also happen if somebody has an infection and is overwhelmingly sick, sometimes with something called sepsis, and they're confused. That's another time that the healthcare proxy gets invoked. If somebody has dementia and they can't make decisions for themselves, that's another reason for it to be invoked. It's really important to pick someone who is going to follow what you want to have happen, right? A big part of having a healthcare proxy is telling that person through conversation what you want. I want everything, do it all. Or I don't ever want to live with a feeding tube. Or if my heart stops, I don't want to have CPR. Those kinds of things are conversations that need to be had regularly with your healthcare proxy so they know what you want. Really important to have an alternate or a backup decision maker. Let's say you pick your son as your healthcare proxy. He's on a month-long trip to Africa. No one can get a hold of him. Or your daughter and her cell phone broke. Your grandchild stepped on it. They threw it out the car window. You know, it's good to have a backup person. And again, the backup person needs to know what you want. So if somebody's name is written down on that form, make sure they know. A lot of times, healthcare proxies are written if somebody does like a estate planning with an attorney. They will write a specific healthcare proxy and you can fill it out at the attorney's office. You put down who your healthcare proxy is, who your alternative is. And when it's done in that setting, it oftentimes has a few special provisions. One of them is for psychotropic medications. So if somebody has dementia and they have a behavioral disturbance and the person says, I won't take that medication, but their healthcare proxy has already been invoked. If the healthcare proxy, again, most of them done with attorneys, say you have to take the medication, their healthcare proxy can say, I want them to have the medication so they're not violent. I want them to have the medication so that they're not aggressive. So that's something to know about the healthcare proxies. Most of the time when you come into the hospital, either through the emergency department or if you come in to have surgery or have an admission, someone will ask you, do you have a healthcare proxy? And if you say yes, they may say, great, do you have a copy of it? Which most people don't carry that around in their pocket. So sometimes they will offer, oh, well, here, just fill this one out so we know while you're here. If you have a healthcare proxy that you filled out with an attorney, and you get to the hospital and they say, no, fill out ours, the second one that you've done invalidates the first one. So if you've taken the time and the effort and the energy to do one with an attorney, don't just go signing them every chance you get, because each one you sign, the most recent one is the one that is valid. And I have seen people who have a really good one. They're like, oh, I didn't bring it with me. They sign another one, and now it doesn't have all the special provisions. So if you know you have one, ideally know where it is. Most of us have phones, take a picture of it. You can, have it in an email, something that you can give to the hospital, but the newest one you have is the one that counts. It's hard for me not to take questions, but I'm going to keep going so we can do questions at the end. Now I'm going to jump to resuscitation. Okay. Resuscitation is what happens when your heart stops or you stop breathing. It's what you see on TV when people do CPR. So when you stop breathing or have severe difficulty breathing, we can do something where it's called intubation, where we put a breathing tube in to your trachea and we breathe for you. We put you on a ventilator and we breathe. There's also something called non-invasive ventilation. If anybody has sleep apnea or has ever seen anybody with sleep apnea, they usually use a CPAP machine, and that's that non-invasive ventilation. CPAP, BiPAP is another word we use for it. I like to call it the squid, because if anybody's seen it, it's this big mask that gets strapped to your face and it helps people breathe. That is something that's only supposed to be used if people are awake and can take it off. So if somebody is not awake and they're not conscious, we don't use that non-invasive ventilation, because if there's a chance that they would get sick and vomit, they couldn't take the mask off and it could go back down into their lungs. So if somebody's not awake, then that's not an option, but the intubation is an option at that point in time. And then when people's heart stops beating, we do CPR. I'm sure people have seen what it looks like on television. I don't know if anyone's watching The Pit, but it's been on all the doctor and hospital shows, including the daytime soap operas for years. What happens in the TV shows is everybody survives. Somebody gets CPR and then they walk out of the hospital a day or two later, the same person they were before they had CPR. CPR is really good for inhaled poisons, drowning, and electrocution. Really, really works well with those three things. Doesn't work all that great for other conditions. These are just some survival rates for cardiac arrest based on ages. And the way it's differentiated in the literature is in hospital versus out of hospital. So in hospital, obviously you're in the hospital. Maybe you're having surgery, maybe you're admitted because you're sick. And if you're in the hospital and your heart stops, obviously there are people that are monitoring you and there are people that are watching, and the response is really much faster than when it happens out of hospital. You can notice here ages 60 to 70 without severe end-stage disease. The in-hospital survival rate to discharge, that means you leave the hospital, is 22% at the highest. Out of hospital, 10%. So obviously those numbers get smaller the more times you go around the sun. Up here to ages 90 plus, out of hospital cardiac arrest, nearly 0% survival. What isn't talked about in that, and what I see, is when we do CPR, we break ribs. If it's done correctly, ribs break. Frequently your sternum breaks. People get pneumonia. They wake up on a ventilator, because if we're doing CPR, we've put a breathing tube in. And you're on the ventilator. So if you wake up and a number of ribs in your chest, maybe even your sternum, have been broken, and you're hooked up to a machine that breathes for you. And every breath causes discomfort with all your broken bones in the front of your chest. Now, that being said, we do not try to be cruel. We don't just do that and walk away. We keep people sedated. We give them pain medication. We do everything we can to make it tolerable, but it's still painful. It really is. So it's not uncommon that people who have CPR and survive don't ever live independently again. And of course, you're more likely the younger you are, if you make it to discharge, to live independently. But it's not uncommon that people will end up in a nursing home. They won't be able to do their, what we call activities of daily living, toilet by themselves, wash themselves, feed themselves. So it really is a difference in how people live, not what they show on TV. So now I'm going to jump to the MOLST form. I have some of these up here and you can go over them later, but they're bright pink. You might notice. Yeah. They're two-sided. In Massachusetts, it's Massachusetts medical orders for life-sustaining treatment. The thought is that we are going to be moving to the POLST form, which is physician orders for life-sustaining treatment, and that's going to be all electronic. That will be wonderful because then it can be accessed anywhere. But we're not there, and I have noticed that Massachusetts is slow in the implementation of these things that we wait for a long time. So many states use MOLST or POLST. Not every state does. Some states have a specific form. I know in Illinois, it's a POLST form. But if you have this form, and let's say you were in a different state and you brought this with you, most states, they would be familiar with something like this. It might have a different box or a different color, but people would know what this was. I don't know if this actually does point. This here is really important. Without a MOLST form, the standard of care is we do everything. We do absolutely everything. And that's just how society is. That's just what we've done since I've been in training. We used to have DNR, DNI forms. That's essentially what this has become now. It's just more standardized. So if you don't want everything done, you have to fill out the form and make sure it's accessible to people. If you want everything done, it's less important, but it's still really important so people know what it is that you wanted. This to me is a document that shows that you've had a conversation. This conversation can start either with your family and your loved ones, or it can start with your medical care providers. It can start with either one. Everybody should know what it is that you want, but that's what this is to me. I see this and I say, somebody's been thinking, and that's really good. Now I know what they want. So flexibility of the form, you can complete it at any time. You can change it at any time. I could complete it and say, do everything, and I could get hit by a bus and everything would be done. I could not have it filled out. I could get hit by a bus and everything would be done. I could get a diagnosis of cancer. I could change the form. I could say, don't do CPR, but breathe for me if I need it. And I could change my mind the day after I fill it out. And we just get rid of this one, fill out the new one, make sure it's signed, and it's valid. So again, it's whatever is newest, but the problem with this, unlike the healthcare proxy, is these frequently go in the medical record. So if you fill out a new one and you change your mind and you want something different done, you need to make sure it gets into the medical record wherever you're going to be. It has to be signed by a physician, a nurse practitioner, or a PA to make it valid. It has to have your signature or your healthcare proxy signature if your healthcare proxy has been invoked, and a doctor, nurse practitioner, or PA's signature. So the front of this, like we talked about before, it covers CPR, which is that pushing on your chest. Now, a lot of times, the fire departments use mechanical compression devices. So it's not even people doing it anymore. There's something called a Lucas compression device, which our fire department in Falmouth uses. They're different names and different ones, but essentially they just do the CPR. So also on the front is the ventilation, what I'd mentioned before, that intubation or the non-invasive ventilation, both of those are on here. And here on the front of this also is one that says transfer to the hospital. And you can say, do not transfer to the hospital unless needed for comfort. So if you are in pain, people will always bring you to the hospital. That's never a question. Or transfer to the hospital. So people are like, well, why would you do that? Well, sometimes people's goals of care, that's another term we use in medicine for what people want, you know, what's important to somebody, because that's really what this means. I had a patient who her goal of care was to be at home with her cats. You know, she wanted to stay at home and she had cats, and that was what was most important to her. And after a few cycles back and forth to the emergency department, and if you're sick enough and if you're old enough, pretty much every time you come to the hospital, you're going to end up at home. And if you don't want to be, that's okay. But then not coming to the hospital is easier. If you have this form and you call the ambulance, or somebody else does, a caretaker does, a friend is over, maybe you have a cleaning lady, they come by and you're having trouble, and you have this form filled out and EMS comes and you say, but I don't want to go. They'll look at this form and they'll say, okay, you know, let's come up with a plan that we think will help you. But look here, you said you don't want to go. This isn't just a rash decision in the moment. And that goes back to that documentation of a conversation. So a lot of people just fill out the front, which is sufficient for me in the emergency department, because these are the questions that are most important to me. But there is also a back to it that again mentions intubation, the non-invasive ventilation, but it also covers dialysis if your kidneys fail, artificial nutrition, like being fed through a G tube or a PEG tube. We also can feed people through intravenous means, and IV fluid hydration. So that means getting an IV and getting hydrated. So those are all covered on the back of the form. These are the things that become more important if somebody is in the hospital for a longer time, you know, a week, maybe dialysis could start within 5 days. These aren't going to be things that I address in the emergency department, but if you're admitted to the hospital, these are things that will be addressed. Not all the time, because not everybody needs dialysis, but these are some pretty invasive things that it's good to have an idea about. And if you don't know what they are, we can talk about afterwards, you know, what dialysis means, what artificial nutrition means, if you have questions. So this is probably one of the most important things, is where to keep your MOLST form. I sign MOLST forms outside of the hospital because I like to have conversations with people and not do it within 5 minutes. So I do it, and when I do it, I sign 4 copies with people. I tell them to give one to their primary care doctor. Because we live in such a unique geographic area here, I say put one in Cape Cod healthcare system. Because that way, if somebody ends up in either Falmouth Hospital or Cape Cod Hospital, they're going to have a copy of it, and we're going to know what you want. Keep a copy with you. Typically, it's on the refrigerator at home. If people are really towards the end of their days, they just pin it right to their refrigerator, and that's where EMS knows to go. I've heard some people, not as much in this state and other states, say they put it in the freezer. I was a paramedic and an EMT for a long time, never looked for one in the freezer. I don't know, maybe I missed some. But on the refrigerator, on the outside is where EMS typically goes to look. If you are at the point where you're having people take care of you, if you have a child take care of you, if you have a caretaker, it's always a great idea to have one in somebody's purse, in the glove compartment of the car. My partner in my business took care of her dad for 5 years, and he had dementia. And she said whenever she was with him, she literally had a a copy in her purse. She had a copy in the glove compartment of the car, so they wouldn't be caught anywhere without saying, this is what he wanted. It can be overridden by a healthcare proxy or yourself at any point in time. So that's what I was saying before. If you have this form, I think it's bad form for your healthcare proxy to go against what you have written down and said. But if your healthcare proxy has been invoked, they can change it. But that's why if you have a conversation with them and you pick the right person who isn't going to be making decisions for selfish reasons, but they're going to fulfill your wishes, then you shouldn't get into that trouble. But again, if you fill it out and you want everything, you want nothing, and you change your mind, we honor what you change your mind to. If you're able to tell us. The big thing is this can be honored by EMS. So if they come to your house, somebody can say they didn't want anything. That first story that I told you about with the woman who died and her husband was sitting on the computer trying to print out the advanced care plan. He printed it out. EMS literally brought this patient into me. They gave me the full medical report. We did this, we did that. This all happened. And then they said, but she didn't want any of it. And they handed me the advanced care plan that had been, 3 nice paragraphs written out with the attorney. And I said, you're right. She didn't want any of it, but they can't honor that. This is what EMS can honor. This is it. So they handed me that sheet. I read it. I said, is her husband here? Went and got the husband and he sat with her and we stopped the resuscitation efforts because I can honor the other, but EMS isn't allowed to. So once they start resuscitation, they keep going until they come to me. I recommend that it is revisited every time there's a change in diagnosis. So if someone has a new diagnosis of congestive heart failure, or if someone has a bad infection and they have sepsis, or if someone has a new cancer diagnosis, it's always a good time to look at it and make sure it still is in line with what you want to have done. If none of that is happening, then it's a good year. I recommend you pick a date and you just look at it once a year. That can be when you go for your annual Medicare screening exam, or you can do it once a year on pick a holiday that you like. I always recommend Thanksgiving because I think it's often a time where families are together and people are with their good friends. So I think it's a great time to say, we've had these things happen this year and I've decided to change what I want, or I'm going to keep it just the same. And I wanted all of you to know you're all here with me now and I wanted everyone to know. So that's a little bit more about the MOLST. So these are the key takeaways. Fill it out. Keep it in strategic places so you can put your hands on it. Have a healthcare proxy. Tell everyone what you want, your family, your doctors, your healthcare proxy, and any caregivers, because they're the people that are likely to be with you. And the first thing anybody does when anybody has a scary experience, if they stop breathing, if they're having trouble breathing, if they die, is they call 911. The first thing that people do, because they don't know what to do. They don't know how to react. And then reassess your wishes annually or after any new diagnosis or change in health status. So this is me. This is how you can get a hold of me if you want. Again, my favorite quote, there is no right or wrong choice at the end of life, but the value lies in making a fully informed choice. And that is it. So does anybody have any questions? Anything you want to go over? Okay.
So your positions in Connecticut, they sign that you are stricken in Massachusetts, is that legal?
So yes, he said, say that your position is in Connecticut and you fill out the form in Connecticut, is it legal in Massachusetts? And I would tell you if it is a MOLST form, then yes, it would be honored. But if you were here and you had a form that looked like this and it didn't say Massachusetts, but it covered the same things, had your signature, a physician's signature, a date, I would honor it. And I think if EMS could recognize it as a MOLST or POLST form, they would honor it as well. But if you spend time in two places, you might want to see if it's not the same form, just have the physician sign both.
Can a physician sign the MOLST form unless it be a POLST?
The physician can sign a MOLST form. Yep. You had a
Oh, I
question?
was gonna say, we have one in Vermont, but we're here in Massachusetts now, and the one in Vermont is legal here, just what you were saying, but we recently each got one of those forms, husband and myself, and to fill out, and they were a little daunting to fill out, I think. I think that's my reason I really came, and so he's filling it out, and it's the listener that's gonna sit down with him. Another week or two.
Yeah,
So, but it's hard to fill out, I think.
it's really hard to fill out, because I don't think people know.
I mean,
It's a lot of,
not healthy. I mean, if you're
it's a lot
not,
of medical words. It's a lot of things, a lot of, I'm not gonna say jargon, you know, they spell it out for you, but you might not know what each of those steps mean. And then it's hard to make a decision. And in my experience, COVID changed a lot of things in the world. There are very few people that have seen anyone die outside of the hospital. And after COVID, during COVID, a lot of the older nurse practitioners that had been working for years and years and years, had been nurses for 30 years and then went on and got more education and certification, retired. And a lot of what has happened is people who are nurse practitioners or PAs and younger they haven't done rotations in the hospital because they didn't have to because of COVID. They haven't seen people have CPR and they don't know how to have these conversations. And that I have seen people fill out, you know, I said there's kind of a stepways thing. So we are not going to do CPR without putting in a breathing tube. And we might for like 3 minutes, but it's not something that goes on because if you can't pick, don't intubate me, but do CPR because it just doesn't medically make any sense. And I've seen plenty of forms that are filled out that way. And I'm like, this is not a good conversation. This is not a good discussion. You didn't understand. So if somebody is a physician or a nurse practitioner or a PA who has been either in pre-hospital care or in intensive care or the emergency department, they've seen this and they know how to answer these questions and they know how to walk people through. But sometimes it's not happening that way. I've had families who have a parent whose healthcare proxy was invoked 3 separate times. And they called the primary care doctor's office and said, we'd really like to fill out the MOLST. And they said, well, you can't do that. And they're like, but we're the healthcare proxy and it's been invoked. And they're like, you can't do that. She needs to be involved. And okay, so if that's the only way you're willing to do it, let's involve her because she wants to stay home with her cats, right? And if she gets CPR, gets intubated, she's not going to be home with her cats. So it's hard to find someone, and a lot of physicians and a lot of people in medicine grew up in a time in medicine where death was failure. And there's a change. Some people now are feeling like, you know, death is natural, and allowing a natural death is something that lots of people want to do. And we're trying to make more space for that in medicine, but not everybody's good at having the conversation. And a lot of people just feel uncomfortable doing it. So if you found someone, that's cool.
So once that form is filled out, and you, physician signs it, and it's put into your health, then you can make copies, like you say, and keep a copy.
Yeah.
Make a copy.
Yep.
And put it in all those.
Yep.
Okay.
Absolutely. If you have the ability, do it on hot pink paper.
Yeah.
Because what happens, you know, if you walk to somebody's refrigerator, this stands out.
Alert. Yeah.
This stands out. So if you have that ability, you know, take it to Staples or take it to somewhere where they can make a hot pink copy, but it will still be honored even if it's not on hot pink paper. It's just harder to find in the moment. Anybody have any other questions? Anything?
Who invokes the healthcare proxy?
The healthcare proxy is invoked by physicians,
Only for the.
Oh. Nurse practitioners and PAs. I think PAs can do it. I know nurse practitioners can in this state. So it would be the kind of thing where somebody is having increasing confusion from worsening dementia, and somebody would write either a form, there's a form that can be signed, or write in the medical record, the healthcare proxy has been invoked.
So an EMT cannot do that.
Nope.
So
No.
there seems to be this, like, why have a healthcare proxy, but that doesn't really apply if you have an emergency, only this.
Well, the healthcare proxy still can apply if there's an emergency, right? The healthcare proxy, it's just a question of getting in touch with them, right? Because not everybody lives with their healthcare proxy or is immediately accessible, right? If you have a healthcare proxy and they are listed as your healthcare proxy when you come into the emergency department and you've had an emergency and can't speak for yourself, I will call them. But sometimes I'm leaving a message, right?
So I thought in one of your slides, it said that EMTs cannot recognize a healthcare proxy or cannot act on it. They can, but they can do it for the moment.
Well, so
I
no, I probably made that unclear. So if your healthcare proxy is there and you have, like, let's say, a husband and wife are at home and the husband dies and drops dead and someone calls the ambulance and the wife is the healthcare proxy. A lot of times EMS won't say, oh, are you the healthcare proxy? Let me see documentation. But if you say before CPR has been started, they didn't want any of this, then they can do it.
So if you have your healthcare proxy in hot pink on the fridge, not a bad idea, because
So I think having them together makes perfect sense, because then that is, here's the next step, because there are a lot of steps between making decisions for yourself and being dead, right? There's a lot of space between them. There really is.
Yeah.
There really is. So that is where the healthcare proxy would be ideal, is in between. I can't make decisions for myself and I'm on the ground.
so you could have whatever, you're on the ground, you're not conscious. The emergency people come, they don't give you CPR, but they take you to the hospital and you survive.
Yep.
And then there's this myriad of things that the healthcare proxy does that this does not.
Yes, absolutely.
I know that-
Absolutely. So let's say somebody passes out, let's say they're dehydrated and they pass out, or their blood sugar's low and they pass out and they go to the hospital. They don't need CPR. But let's say they have a bad infection. And so for 2 weeks, they're really confused. That is where the healthcare proxy would jump in. Yes.
You should have both, right? They both get.
You should have both. But it's super important that you tell your healthcare proxy everything that you want that's down on here. The other thing that does, that this MOLST form does, is it absolves your healthcare proxy or your family or your friends who would make those decisions for you. It absolves them of the guilt, right?
Yeah.
Because what I say, when I have this conversation, I say, do you know what they would have wanted? Because that's what's important. It's not the decision that you make for them. It's what they would have wanted. And you're just here to convey that to me and the healthcare team. So this is hard for people to see. I was just with a girlfriend out of town and we were talking, and her dad was in his mid-70s and she was going away on a trip, and he said, oh, I just went to the hospital because I was just having a little chest pain, and ended up, having, he just needed stents. He didn't need a bypass, but he had poor circulation to his heart and needed an emergency intervention. And she said, I don't want him to have this because I'm not ready for him to be gone. And I said, but what you've told me is your dad took care of your grandma for 15 years while she had severe dementia. And what he's telling you is if he were to die, he would prefer that than being someone with dementia that you took care of for a long time. And she goes, oh. So this is a form that helps people not make decisions of what the patient wants, which is hard.
But this is, the extension and siblings, talking about what is, how we take care of them.
Yeah, and it's that's very common. That if they're multiple children, they all have a different idea. Usually one or two might live close by and are very involved and they see differences as compared to people that live further away. And the people that live further away might not know how sick someone is or all the trouble they're having, and they show up at the last minute, so you have to do everything. And you say, well, mom said right here she didn't want it all done. So this really can cut down on that discord in the family. Yeah.
Could you explain a little more of the IV hydration?
Yes.
Because there is two schools of thoughts about that, that it can that follow the best.
Yep.
Or the other one, but it helps them not to.
Yes. So the question was, can I talk a little bit more about the IV hydration? There are two schools of thought. Sometimes some people feel like it makes people feel better and it makes people more comfortable. And then the other thought is it can prolong death. And I would tell you, yes, at the end of life, I am in the school of thought that I think it prolongs death. Okay, I think that it is something that keeps the body going when everything else is shutting down and the body's trying to shut down. That being said, I use IV hydration all the time because people are weak, they're dizzy, but not when they're actively dying. So I think IV hydration when someone isn't actively dying is very, very reasonable. But when someone is actively dying in the last stages, in the last 5 to 7 days of life, I think it really can prolong things. They can get in the way and it can make it take longer.
That's very interesting.
You like that?
Think of death as like, it happened, but it's a process.
It's a big process. It really is a big process. Somebody else.
Stipulate that, ideally and up until the end, what would you call that? End of life,
Yeah.
because it's definitely a process, I think.
Yep. So here, artificial hydration, nutrition, and then dialysis, they say none of those, you can fill in a little bubble, or you can say use it, or you can say use it, but short term only. So this is where if somebody has I was just actually talking to somebody. This is where if somebody has a living will or an advanced care plan that they could put in with their attorney, they can say, IV hydration, but for no longer than 7 days. Or it's okay to give me artificial nutrition, but no more than 7 days. Because by the time that part comes into the medical decision-making, there is time to get the living will or the advanced care plan that is somewhere in your legal documents. There's time to get that and bring that into the conversation with the healthcare team.
So there's no more DNR, is that like one wrong?
Yeah, the form is really gone.
Wondering. And then, can you speak a little bit more about living wills and how they fit in with, it sounds like the MOLST is right away, but how it fits in with the healthcare proxy? And like
Sure.
cons, the difference.
Sure. So the living will and the healthcare proxy are together known as the advanced care plan documentation that happens with attorneys. And the healthcare proxy we've talked about. The living will is that, paragraphs of if this, then that. If I was hit by a bus, only keep me alive for a week. Because if I'm not improving by a week, then I don't want to go on living in a hard way. The living will can stipulate everything that there is between I can't answer questions for myself. I can't tell you what I want with my words anymore and dying. And that is where people sit and they think about things. It can be 7 pages long. It can be 3 paragraphs. It can stipulate anything you want it to. But it is not, it is going to come into play if there is no MOLST form. If someone has had a need for hospitalization and they don't have a healthcare proxy, because the healthcare proxy can use the living will to communicate the decisions to the care team. The other thing about this that's really interesting in Massachusetts, and it isn't always this way, there is no, the living will in Massachusetts isn't something that is quote unquote recognized, so it's not something that has to be honored.
Really?
So it can be done and the care team can say, we know what's best, we're gonna do this. And I don't know of situations where that's happened. And I think it still offers a ton of information for the healthcare proxy. But it also can be a rabbit hole that people go down, right? It can be 15 pages long and it can give all these ideas of what you want done that can be hard for somebody else to interpret. So it's best to keep it simple, but address what's important.
Well, if you have a MOLST form, I mean, that's.
Well, so if you have a MOLST form, that's gonna, I still think that there's a good thing for the living will, but it is that it helps make decisions if somebody is not able to speak for themselves and they aren't to the point where their heart has stopped or they need to put in a breathing tube yet, right? So again, they can't communicate, but they're not on the floor needing resuscitation like we talked about. So it can say things like, if I have a horrible infection and I have been in the hospital for 2 weeks and I'm not improving, I don't want you to go on and do more. It can say, if I have a horrible infection, and sepsis is this word I've used before, and I have bad sepsis, all I want is antibiotics and fluids. I don't want you to put a central line in, which is a more invasive thing. I don't want you to put a feeding tube in. So it can give more detail than this form, even the front and the back does. But again, if you have these conversations with your healthcare proxy, hopefully they'll know what you want.
Well, Dr. Todd, you're making the point that it's all about qualifiers, if and then. I wouldn't know when it's inappropriate to have a central line or whatever you call that. I wouldn't know when
Right.
sepsis and sepsis, you know, when I circulated the drain after 3 days or 3 weeks. And we're, you know, shooting around in the dark, unless we really have medical knowledge.
Or you can say things like, if people feel that my care is futile, I don't want
What do you think?
I don't want any more.
Right.
You know, from a very young age, I have one brother who's older than me, and from a very young age, my father always said to me, you're making my decisions. If I can't decide for myself, I want you to make my decisions. This was before I was even an EMT. And I'm not sure why he always felt that way with me, but that was how he started a relationship very early, like, you're going to make these decisions. And he would use vague language. I don't want to be kept alive on machines. Okay, well, now that I have so much medical knowledge, I'm like, we're going to give you 2 days. We'll see what happens, right? It's not, I don't ever want to be on a machine. I don't want to be kept alive. And, you know, just because family dynamics are so fun, right? My mom said, well, it has to be fair. Your brother's making my decisions. I said,
Okay.
great, Mom. He's not a doctor, but okay. So, so the thing about the living will and the healthcare proxy in this form, things change. You know, what I saw with my husband, what I saw with Evan, he was a doctor, right? He knew very many things that I knew. He worked in the emergency department. He said to me, if I'm not Evan, I don't want to be. And I'm like, that's really vague. Like, that's really, really vague. And he would draw a line in the sand and he'd say, If I can't do that, if I can't walk, I don't want to live. You go, okay, I'm gonna make a new line. I decided I can handle that. If I can't speak, I don't want to live. So things change, when circumstances change, when diseases change. Your idea of what I can live with changes as you get closer to what you've said you can't live with. And that's where having a healthcare proxy who you can have these conversations with regularly makes a big difference. Makes a big, big difference.
From what I understand, the healthcare proxy has some information that mostly is the person.
The healthcare proxy is a person?
Right.
Yes.
It's really the person that you're designating, even if you have a list of things in there. Right. But it's both.
Well, the healthcare proxy, with that form, you designate a person to make your choices for you. And there are certain things that the state of Massachusetts likes to see reiterated, like you can give psychotropic medication, feeding tube really isn't another one that's in there. It's mostly if somebody has dementia or a behavioral disturbance, we'll call it that, because it could be that they have mental illness like schizophrenia or something where if you are the healthcare proxy and it has been invoked, you can say they have to take the medication or they hit their head, or they hit their head, or they hit their head. Yeah, they had a head injury.
So, but okay, so I'm sorry, I'm getting nitty gritty here, but
There
so
we go.
that'll be my healthcare proxy.
Yep.
Right? And yet, if we both die in an airplane crash, but I survive, somehow I get ejected. I have some other backup.
Yep.
See? And there is some instruction in that healthcare proxy. Is that correct?
Not really.
No.
No, there's really no instruction in healthcare proxy. The instruction, well, the most would be that end of life, but if you have a living will, that's where the healthcare proxy would go to see.
Do you need all of it?
You do, you do.
But a living will is not recognized.
But
It's so queer.
Yeah,
So
it is.
unfathomable.
It
So
is.
have you heard of a living will called the 5 questions?
Well, I have heard the 5 questions, yes. Yeah.
And that's recognized in some states, but certainly not here.
Okay.
Because, and no living will.
Right. Right.
So if the healthcare proxy comes up to, well, I have this in this document, I really think this should happen. And I've been in I am not a person, but I've been around a lot. And there are some physicians who are lovely, and there are some physicians who are horrible and just say no, or do what they want, or are insulting. I've seen it personally. And so, what's the recourse? How do you deal with that if it's not recognized legally?
So I think if you are the healthcare proxy and you have that living will, you have somebody's 5 wishes, it tells you what they want. As the healthcare proxy, you can say, this is what I want you to do.
So they have to be a tenacious person.
Very tenacious, very tenacious. And what you're saying, I'd like to say, oh, no, that's never happened. I've seen it happen. I've seen it happen. In emergency medicine, we move at a very fast pace.
Of course. Yeah.
Things are crazy and chaotic, which is how I enjoy it. I have 5 kids, I like chaos. And it's faster to do everything than it is to have a conversation.
Right. Or read something, or deal with a human being.
Yeah, because it's also emotionally challenging to deal with the human being. And it brings up experiences that you've had with death when you talk to somebody who's taking care of someone who's dying. And that's hard. So,
Also seen it in slowly.
yes, yes.
Okay, so I have a much better grasp of what's going on. And so you're saying the MOLST is just Massachusetts. MOLST is in several states, or?
Many states use the most. So MOLST and POLST are looked at as the same thing. They're just slightly different. And they're used in, I'd say right now, about 1/3 of the states. If someone brought me a MOLST form that didn't say Massachusetts on it, I would honor it. I think EMS would too, if they saw a signature by a healthcare provider, a patient or the patient's healthcare proxy, and a date. Those are the things we look for. Then I think they would honor it. But certainly if you make a move to a different state, get a new one, but bring the one that you have if you're going in between states, because it will still be honored most of the time.
That was my next question. I don't know how to find it, but, so if you're traveling,
Mhm.
bring it with you, even if you don't know if it's stable.
Yeah. Yep.
And better the healthcare proxy and the living.
Yep.
All in proxy.
Take it everywhere, even if you're going overseas.
Yeah,
It couldn't hurt to have more
Right.
information.
right. My parents just came there in Illinois and,
Doing the first one.
you know, she mentions the 5 wishes. As I went into this business, I said to my parents, we need to sit down. I need to understand. I said, Mom, I know I'm not making your decisions, but still tell me what you want because I want to know. And she said, well, I've already done it all. I've done it all. And she pulled out her 5 wishes form from the attorney and it had her name and her birthday. She hadn't even cracked it open. She hadn't looked at it. She hadn't read it. She hadn't answered any of the questions. She's like, I'm all done. I'm like, no, Mom, you're not all done. So we went through things. We filled out her MOLST. She took it to her primary care doctor who signed it. I said, fantastic. And she brought it when she visited this last month, which I'm like, we're making progress.
So, so if you come in and you can't make your own decisions and your healthcare proxy comes with a living will and says, this is what they want. How often is that overridden? When you have both of those?
So I don't see many people bring in their living wills. And again, I'm just like that immediate resuscitation in the emergency department. All the time that I spent in the ICUs and training, I didn't see it overridden, but you guys can tell I have a strong bent for what I think is important, right? Which is honoring the patient's choices, even if they're written down and if we know what they are, that's what I think is the most important. So I haven't seen it happen, but I'm sure it does. I mean, I'm sure it does. But no one should, if you are the healthcare proxy and you say, stop this, don't put a feeding tube in, no more dialysis for my loved one. Nobody should challenge you on that. But we know there have been court cases throughout history and different things where, you know, pregnancy can affect what people think is autonomous for the patient, or competing interests between parents and a spouse. They can have different things that they want to have happen. And so there have been court cases, you know, throughout my lifetime where that has been adjudicated. So it shouldn't happen, but you have to be tenacious. I mean, if anybody's had interaction with the healthcare system lately, everything has changed since COVID. Everything is really fragmented and kind of broken apart. It's hard to get a primary care doctor. You know, this old Marcus Welby, MD, primary care doctor that took care of you from the time you were born until, you know, the time you died. You're lucky if you see the same person if you go back to the doctor's office twice. And I find that I do a lot of this care of telling people, you know, somebody is in the process of dying. It might not be immediately, but they're never going to get better from where they are now. And nobody says that. And that's really hard for people to hear. But I think it makes people make different decisions when they know the reality of what's coming next. And I really think informing people of what's going on and what's to come, and that makes a big difference.
You have that MOLST form scanned into your Cape Cod healthcare, then it's there, right?
Yes, it's there.
There.
Yep.
Oh.
Yep.
But you want the EMS people to see it, so it has to be, oh, that too, but I mean, as far as the hospital.
As far as the hospital,
They've
yeah,
got it.
we've got it. We've got
Like
it.
if you're up in Boston.
And that's why when I sign, I do 4, right? So people can take one if there's a facility that they use in Boston or out of state. They have one here, their primary care doctor has one, and then they have a personal copy either on their fridge or with them. Yeah, yeah. Any other questions?
I have a question which did you mention that you are a guest doula?
I am, yes, I did.
Is that part of that program that you inspire what you do?
Is it part of the program?
I don't know.
Death doulas aren't that big on Cape Cod yet. I have done the training and I have honestly not even run into anyone that's actively attending deaths in the death doula capacity here on the Cape. There's another physician that I'm friends with who did it together. I know she's not using it. I have run into one or two people that have come from out of state that have relocated here that have the training and we're trying to set up a business to attend deaths. I haven't run into them again. So I don't know anybody who's doing it here. That doesn't mean it isn't happening. It just means that I don't know. But it's an incredible thing. I mean, my first experience with doulas was birth doulas, and that was incredible. And to have, just to have somebody who has been through it in the room with you while it's going on makes a big difference. Makes a big difference. Yeah, and it's not even necessarily holding the hand of the person who's dying. It's figuratively holding the hands of all the people that are with them. I'm just going to mention, I do have some MOLST forms up here if anybody wants to look at one or take one. I also have my card, my partner's card. There's an end of life plan with caregiving pathways that you can it's a bunch of different questions. And then how to help, this is a pamphlet that we have on our website, but it's how to help a loved one in a hospital stay. Just some things. The other part of caregiving pathways in my partner, it's supporting family caregivers because that's a big part. But my passion is the end. When I die, I want to have animals on my bed. If I'm at a stage of life where I don't have my own animals, I expect my friends or neighbors or whoever to bring their animals and put them on my bed. Yep. And there will be no fighting in the dwelling that I am in. People can fight, but they have to go outside. No one is allowed to fight in the building where I am. Other questions on this is, are there people you want to have there? Are there people you don't want to have there? Are there smells that you want to have? What do you want to look at? None of that to me right now is as important as the animals and no fighting. So.